Hi, Robert Imhoff. I'm the President and CEO of the Maryland Patient Safety Center. We also involve ourselves in a maternal and infant health initiative every year. 2 years ago, we were involved in reducing early elective deliveries. Early deliveries are 30 or less than 39 weeks without medical indication. There are times when it is necessary to deliver a child early. However, a lot of times, there have been many cases where individuals will deliver a child early out of convenience. And some of those reasons for convenience are very appropriate. In fact, we had several cases when our troops were being deployed overseas that father wanted to see the child born before he went overseas. So there were cases where those deliveries were scheduled so that that could occur. However, there are instances when the need is not as pressing, and we would stress that hospitals have policies to dissuade patients from doing that because the safety and to both the mother and the child is at risk. So we worked with the hospitals, we worked with the Maryland Hospital Association on helping establish policies. We ask that each birthing hospital, there are 32 in the state of Maryland, establish what's called a hard stop policy, meaning if there is not medical indication or there is not a very compelling reason for an early elective delivery, that they not schedule those procedures. I'm happy to say that in December of 13, we hit for the first time a 0% or a zero rate of early elective deliveries within the state of Maryland, and they have gone below 5% consistently. So we're very pleased with the success with that program. We're embarking on a program similar to that this fiscal year, which we are just getting underway, toward reducing first-time C-sections. And similar situations, or there are similar circumstances around the first-time C-section rate that we saw with the early elective deliveries. C-sections are major surgery. Patients are not always aware that that's the case. We want patients to be educated more about what's involved with the C-sections. We want greater disclosure to the patients about what's around that, what the safety factors are, and we feel that there is a lot of room within the birthing community to reduce that rate. The Maryland Patient Safety Center for many years has been focused on hospitals and the care they provide. Hospitals for many years have been the epicenter of healthcare in Maryland and throughout the country. However, that has changed significantly over the years, especially in Maryland where there is a new waiver. We're the only state in the country that is under this global budgeting, this total patient revenue model, and it's a bit experimental through CMS. But it emphasizes not just from a reimbursement perspective, but also from a quality and safety perspective, the need and the dependency on all healthcare providers. That hospitals can no longer act as the one stop for care. So hospitals have to better coordinate with primary care. They have to better coordinate with post-acute, long-term care, rehab, surgical centers. They all need to be part of the equation because that patient doesn't just begin and end at the hospital door. Doesn't begin with the admittance to the hospital and end with discharge. There's medication reconciliation. There's follow-up with your primary care physician. Many times, especially with elderly patients, they're into a rehab facility afterwards or some other type of long-term care. So to make sure that patient's receiving the safest and the highest quality care possible, there has to be a strong coordination between all the healthcare providers. So it only makes sense that the Patient Safety Center follow that same model and involve ourselves with all providers. So I like to remind people we are the Maryland Patient Safety Center. We are not the Maryland Hospital Patient Safety Center. So we want to make sure that the environment of care is safe throughout the healthcare continuum. But the crux of this is it allows federally listed patient safety organizations to take certain information in, which is called patient safety work product, and it becomes confidential and non-discoverable within the patient safety organization. And the point of this is that, and adverse events is a perfect example. Hospitals can share the adverse events that they're experiencing with a patient safety organization, provided they follow certain rules and compliance methodology. They can share that information with the patient safety organization. The patient safety organization can then gather that information from a number of sources, and it just doesn't have to be just hospitals. It can be long-term care, it can be anywhere. Take that into the organization and look at what's going on out in the marketplace, as it were, to see what's going on in the hospital community. Where are the issues? Where are the challenges? Is it falls? Is it pressure ulcers? Is it sepsis? Whatever that issue is. The Patient Safety Center organization, the Maryland Patient Safety Center, can then go back to the hospital community and say, these are the trends that we're seeing. These are the things that are going on within patient safety, within healthcare right now. So Hospital A may not be familiar with, certainly wouldn't be familiar with what Hospital E is doing. So the fact that we are a repository, a safe repository, a protected repository of this information, we can share that information de-identified and on an aggregate basis with everyone so that they can learn from what's going on with their, I don't like to use the word competitors, with their like hospitals around the state, within their county, within their region, and also throughout the country. So the reason it was set up and the reason this information became protected and why the federal government rightly felt it was necessary is so that information could come to one central location and be used as a learning tool. We also do something called safe tables, which is another activity of a patient safety organization where the discussion is protected. The comments, there are no notes taken, people can speak freely around the table. And we do this 3 to 4 times a year where we bring in patient safety officials or whomever's appropriate for the discussion around a specific topic. It could be alarm fatigue, it could be workplace violence, the list is very long. So we bring people in to talk about what their hospital is experiencing kind of real time, to talk about what is working well, what isn't working well, so that they can hear from other hospitals, from other healthcare providers, what's working well for them. So this exchange that otherwise wouldn't happen because of these protections allows hospitals to learn from each other. So it's very beneficial in that.